Welcome back, everyone, to part 73 of our massive 100-part CPC exam series. I am absolutely thrilled to have you here today because we're tackling some of the most highly tested and honestly most frequently misunderstood guidelines on the medical coding exam. But before we jump in, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Your support really keeps this series going.
Look, I know study fatigue is a real thing, but I promise, today's explainer is going to make outpatient sequencing completely effortless. We've got a clear roadmap of the high-yield traps we're about to tackle. Here's our agenda. 1. Welcome to Z-codes. 2. Primary versus secondary Z-codes. 3. Screening versus diagnostic encounters. 4. Social determinants of health. 5. Outpatient diagnostic golden rules. And 6. Our summary and exam teaser.
Okay, let's dive into this. Section 1. Welcome to Z-codes.
To set the stage, we really need to understand exactly what Z-codes are. Found in Chapter 21 of the guidelines, the 00 to Z99 series captures encounters where a patient just isn't currently sick or injured. Picture a completely healthy patient coming in for a routine annual physical, maybe a preventative immunization, or just some routine post-surgical aftercare. These non-disease circumstances are heavily tested on the CPC exam, and knowing exactly how to sequence them is absolutely crucial for grabbing those points.
Moving right along. Section 2, Primary versus Secondary Z-codes.
Now, what's really interesting about this is the stark contrast between codes that can stand alone as a primary diagnosis and those that are restricted strictly to secondary status. Primary Z-codes mean that if a patient comes in solely for, say, a general adult medical exam, you'd use Z00 as your very first listed code. But secondary-only codes, like Z79 for long-term drug therapy or Z99 for machine dependence, they strictly supplement your main diagnosis. They tell a broader clinical story for sure, but they literally can never act as the primary reason for the encounter.
Section 3, Screening versus Diagnostic Encounters.
A screening is basically testing performed on a completely asymptomatic individual, just to detect a disease early on. The primary screening code rule is totally non-negotiable. If the purpose of the visit is a screening Z-code from the Z11, Z12, or Z13 series must be sequenced first.
But wait, what happens if the doctor actually finds something during that screening? Well, this brings us to the abnormal findings rule. Let's say a patient comes in for a routine screening colonoscopy, right? And the provider discovers a polyp. The exam will definitely try to trick you into coding that polyp first. No way, don't fall for it. Step 1 is always sequence the screening Z-code first, because that was the original intent of the encounter. Step 2 is to sequence the specific code for the abnormal finding, in this case the polyp, as secondary.
Section 4, Social Determinants of Health. I need you to put a huge star next to this one. The Z55 through Z65 categories cover high-yield topics like economic disadvantage, low literacy, and housing instability, like code Z59. Here is a massive high-alert exam trap. Unlike standard clinical diagnoses where you strictly need the attending provider's notes, SDOH codes can actually be reported based on documentation from any clinician involved in patient care. Why? Because social workers, case managers, and nurses are usually the ones having these crucial lifestyle conversations with patients. Their notes, or even self-reported patient questionnaires, are totally valid for assigning these codes. It's a real game changer.
Section 5, Outpatient Diagnostic Golden Rules.
As a master tactician taking this test, you must memorize this list of forbidden words. In an inpatient setting, you might be allowed to code a suspected condition as if it exists. But in an outpatient setting, never. You must absolutely never report terms like probable, suspected, questionable, rule out, working, or consistent with as confirmed diagnoses. Just don't do it.
So the crucial point is this. The outpatient rule says you must code conditions to the highest degree of certainty. If an outpatient diagnosis is unconfirmed, you cannot code the suspected disease. Instead, you've got to code the signs, the symptoms, the abnormal clinical findings, or the chief complaints that brought the patient in. For example, if a note says rule out appendicitis, you code the right lower quadrant abdominal pain, not the appendicitis. And right alongside that is the chronic conditions rule. You should always report all coexisting chronic conditions that exist at the exact time of the encounter, provided they require treatment, management, or clinical evaluation by the provider during that specific visit.
Finally, Section 6, Summary and Exam Teaser.
Go ahead and take a screenshot of this one-page visual summary cheat sheet, and this brilliantly illustrates exactly what you need to memorize, the primary versus secondary differences, the unshakable screening rule, that huge SDOH documentation exception, and the strict outpatient unconfirmed diagnosis rule. Keep this handy as you take your practice tests.
Which brings me to my final question for you. Medical coding isn't just about matching numbers to words. It's like a giant puzzle where you translate a patient's true clinical story into data. Will your codes tell the right story or an unconfirmed one? In Part 74, our CPC exam practice masterclass, we're going to put this knowledge to the ultimate test by dissecting high-yield case studies and common exam pitfalls. Keep studying hard, trust the process, and I'll catch you in the next explainer.